Thank you so much, Ron. And Nick, thank you in particular for being willing to step in. I know that I always appreciate our conversations, and I know that this will be helpful for the audience. So I guess I wanted to just start. So we've heard from Dr. Deshali about the broader epidemiological view, and Dr. Buer from the kind of structural and policy view. In terms of what's going on with hepatitis C and people who inject drugs, what are you seeing? And I guess, maybe start with your vantage point in Indiana with the Indiana Recovery Alliance. But you also work nationally, and I know that you talk to a lot of colleagues about what's happening with drug use, with overdose, with viral hepatitis, including, some really interesting projects that Urban Survivors Union partnered on in terms of the More Than Tested Cure project. So what's the view from your vantage point?
Yeah, Daniel, I'm glad to be here, and I'm especially glad to talk about it in this context. I'll first start that I was infected with hepatitis C, tried to get the cure, and could never get cured, so my community cured me. So I never received a medical angle. It was just through some friends in my community cured me. So that kind of gives me a particular vantage point, especially being here in Indiana. Just recently, the Scott County Syringe Service Program was shut down, or it was slated to be shut down in January of 2022. Through a lot of robust activism and help and data, the Austin City commissioners have now gone ahead and voted yes for there to be an SSP in Austin City. So that during all the turmoil of these attacks and these SSPs shutting down, that's one small win in a vantage point where we just constantly feel under fire. Hepatitis C is something that I personally understand the ravages of, and especially in places like Indiana or rural West Virginia or North Carolina or Georgia or any of those places. It's one of those things that's hard to even quantify because people have spent so much of their time trying just to stay alive. Things here are slated. It's a constant feel of people. Now that the boomers are cured, why should people care that the only people who are new infections from people who use drugs? And even nationally, it's looking that way. And it's seeming more and more we have partisan politics playing a role in the curing of a disease. There are no new stellar breakthroughs. We have not, trampled into dried blood spot testing. We are not making innovations. Things from my vantage point look very stagnant and very bleak. Indiana is the number one state in the nation for acute hepatitis C infections. And nothing's being done. The same things that have always been done. We got rid of barriers. So it's bleak in that sense. I mean, not only is it bleak, but it doesn't seem to look as if we're making our point well enough or if we're pushing through.
Yeah, thanks. I hear a lot of that as I talk to people, especially on the patient side, the frustration about where's the sense of urgency. And I think about what you said at the beginning that your community cured you, and thinking about what that looks like in practice. That our colleague Louise Vincent, who is also on the planning committee for this event, did a storytelling project not that long ago. And I felt like I learned a lot from her about how the stigma around hepatitis C is interwoven with gender-based stigma around substance use. And that interplay that sometimes I think when we talk about stigma for diseases like HIV, sexually transmitted diseases, or historically cancer, we think about it as a somewhat disease-specific stigma, that this disease is scary and people are scared of it. But I think the hepatitis C story is a little different, that the stigma around hepatitis C might not solely be, but is so heavily intertwined with stigma around injection drug use, and that manifests in different kinds of levels. The kind of structural or policy level that you talk about, that why should anybody care if they don't care about these people who deserve punishment or didn't need to take this risk, but also internalized stigma that people inherit or internalize this sense that, well, maybe I'm not worthy of a cure. If that's what the message that I'm getting from everybody, then maybe this is just my lot in life. Maybe this is just my fate. And I'm wondering if you have some thoughts about how that plays out.
Yeah, I think one of the things I learned from a lot of working. So there's a program that's going on right now for 3 different agencies in different locations. It's called the More Than Tested Cured. It's been going on for 4 years. This is the 4th year of its iteration, and it works with helping people use drugs and people with hepatitis C, finding the barriers, breaking the barriers, but more than that, finding stigma and breaking down not only the stigma that's placed from external forces, but the stigma that's placed in internal forces. And that's kind of like when you're talking about it, like we worked on disrupting narratives, disrupting social narratives around hepatitis C. And what we found out was that most of the time, it wasn't so much that external pressure was there, although it's kind of a lizard brain societal feeling that because people who use drugs have put themselves in that place and that they don't care about their health, and that people whose drugs are just winging it and we can get a cure, so why do we care? It puts a real hard bias internally as we parrot that back to each other and then shove that stigma onto each other. And it's a strange situation where, just the same as with these things with the drug war, like, we tell ourselves things like, prison saved my life, or, I'm glad if I wouldn't have gone to rehab, I'd be dead. These things that put an onus on an untrue equation. You might not have been dead. You might have died if you didn't go to prison, although you might have had a wonderful life, not had a record, not had a lifelong dealing with the carceral system, which will plague you way worse than anything else you could ever have, And I think until we're talking about treating the whole person, like when we focus, especially at when we're talking USU and IRA and NCSU, we focus on the whole person. You know what I mean? Like you have to look at entirely what's going on before you can even begin to treat hepatitis C. One of those in the program you're talking about in the story sharing, we realized that like someone will come up with an idea. Hep C is transmitted via sexually, through sex. That'll translate when we give them the test results, if we're not careful, to coming home and bringing that to that person's partner, who will then say, you must have had sex with someone else. What have you brought home to me? So not only do you have the internalized stigma of this person knowing they're going home to deal with this, but then you have it parroted back and ratified by the person they come back to. And this is just one idea of the things that, like, the cascade of stigma that rolls through. And we talk about stigma all the time, and we don't really understand that it's like mental health. It plays a huge part on what we do in this world, like how we move, who we are. As a person who uses drugs, I don't understand some of the healthcare. We're trying to solve this problem through a healthcare perspective, when really it requires something that people might have to get a little dirty. They might have to have uncomfortable conversations. They might have to like truly meet people where they're at. A lot of us people who look at the situation with HCV and they go, well, it takes so long to get cured. I'll figure it out later. There's a cure. I went in there once to get a test and nobody, they never got back with me. Or it takes 2 weeks to get another test and they walked away, And it's only through the people we've been able to touch with stuff like the narco-feminism story sharing model that we used with More Than Tested Cured, and the social media we put out because of that some people are starting to push that away. Then you get into society and things with policy updates, and you see people crushing SSPs, the bill in West Virginia, the attempted bill, 334 in West Virginia, Bill 607 in North Carolina, the attempts are, what happened in New Jersey, of all places, that internalizes us to feel like, well, we're not, they don't even want the smallest of things open for us, which in turn makes us think, well, I mean, why would I get cured? It's too much of a problem, And that is the lizard vibe that's the vibe we're getting back from society as a whole. You know what I mean? We feel like society feels like, we don't care. So people use drugs. You're not baby boomers. You're not, this or that. When in reality, we need to be if we treated the whole health of this person and really like started to talk about the stigma that's changed their mental health, start to talk about, all of the Maslow's hierarchy and needs stuff, we would get into a place where that person was way comfortable with getting Hep C cure and treatment. They could even maybe wait a little bit. But you can't expect someone in chaotic use to care about that if they don't even feel like you care about it. You know what I mean? They just feel like you're checking a box.
Yeah, thanks, Nick. And I think what you've laid out is a really kind of elegant exposition about how stigma at the structural level plays out at the interpersonal level, plays out at the internalized level, and that we often talk about. Let's do a little, let's do a poster campaign to destigmatize this or that, but we need to be talking about this simultaneously at these levels, and that stigma is a social determinant of health. I wanted to turn a little bit to kind of think about how to fit hepatitis C into the current work and strategies and policies that are happening around overdose. So today, CDC released its updated provisional data for the most recent 12 months of overdose deaths. And they have been releasing this month by month. I think the latest one is May 2020 through April 2021. And what they reported was 100,000 overdose deaths, which feels monumental, on top of the hundreds of thousands of people that we've lost over the last 20 years. And while they didn't have demographic data yet, they were seeing these increases in overdose in virtually every state, significantly heavy increases in two of the top three states were Kentucky and West Virginia. So there is a sense between the COVID pandemic, between overdose, and between the ongoing grinding toll of incarceration and homelessness that the people most vulnerable to viral hepatitis, to hepatitis C, people who inject drugs, are under siege on all fronts. And, that kind of begs the question. You talk about kind of addressing the whole person. What are the ways that people who might be in an emergency department, they might be a recovery coach, they might be a harm reduction outreach worker, but they do have some kind of touch point, some kind of access to people who are contending with multiple competing risks to their health, their dignity, their personhood? How do we kind of take that complexity, but put it into practice?
It's good, Daniel. That's really, I hate to say this, but we have to go back to the training. People are not trained. I've seen many people who give test results, who deal with staff, and the trainings are usually done by some place that has had, input from people who use drugs. But we are never at the point where we are creating our own stuff. We're trying to at USU, but I mean, like, it's kind of like a chicken and the egg thing, It's like every time I come up with this question, what could I tell them that would reach me better? What could I tell someone that would turn the tide? And there are simple things that are like, knock you on the head. Why aren't we doing this? Like dried blood spot testing, point of care, RNA confirmatory testing, sending people with a little bit of hope out there in some way that maybe getting the cure within the same time that they're sitting here. But before all of that, we have to look at how those people are being treated, and it's not uniform. It's not like we have a uniform training across the lived experience world or across the healthcare connection world. We have best practices, and we have, these things that people trying to get there. But if we're going to start addressing people who use drugs, and we're going to start consider them, we're going to have to go all the way back. We're going to have to go back to the training board. Training wheels on. Okay, how do we do this? This is a new world. We are not dealing with heroin anymore. We are dealing with fentanyl. Your average person used to use dope. They'd go out, do a shot. They probably wouldn't overdose. Even long into their storied history, they might have maybe came close once or twice. You're now looking at roulette every time. You're looking at stuff inside of these drugs that is just unreal, like, the xylazine that almost killed Louise. Until we start talking about putting a person there, training them to deal with the whole health first. Like, so we get. I guess let me simplify it this way: we send a harm reduction student worker to a place. They've been taught harm reduction 101. They've been taught medical triage. They've been taught, confrontation de-escalation tactics. They've been taught how to test, and hopefully maybe how to provide counseling after the test. That's rare, but sometimes they do if they're testing for HIV or HCV. So we've already moved into this place where we haven't talked about, have you made that person comfortable? Have you met them where they're at truly, not just, physically? Then we haven't talked about, have you addressed the person's other needs? This person may be in chaotic use. They may need housing. They need this. They may need that. You might not know what's going on. Maybe they're in an absolute craze because they just lost the person they loved and they don't know what to do. So the answer is we have to go back to the training of the people that are out there, which is going to be hard because most of the stuff is hard ingrained. If we trained right, and if we had things like point of care testing, and if we had true decision making, the training done and created by people who use drugs, it's the same thing with cancer. They were having a really hard time with cancer and the treatment of cancer and all this. And there was lobbying by people to get people who had lived through cancer to help. And they only turned the tide at that point because most people, now cancer education is a lot of the way that we deal with people who are having cancer is a whole different world, because those people had the input into directing the care, into teaching the people that give the care, and until we do that, we're just spinning a wheel saying we got some representation for people who use drugs and we check that box,
Yeah, thanks. And that makes me think. I know I heard from my colleague, a member of MVHR's Voices for Hep Advocacy Network, Deb Grainer, that Kentucky had a meeting yesterday to start their planning for Hep-Free Kentucky. And a lot of states, and I know, Nick, you were involved with this with Indiana's HIV and hepatitis plan, are going through these planning processes. So I guess I want to give you a moment. As states are moving towards developing viral hepatitis elimination plan, what is your elevator pitch for engagement and meaningful consultation and input of people with lived experience, people who use drugs?
The idea is that if you want, I wish I could say this statement about the bowl and the steak, about the idea is that in our plan for Indiana, what we did is it started from a plan that began with Dan Big and Louise. And it created, and the whole idea is it needs to not just include people with lived experience. It has to be centered and directed by people with lived experience. And this is a hard thing for healthcare to get a hold of. It's a hard thing for the state to get a hold of. Nobody likes to give up their power, their whatever. If you are going to have a viral hepatitis elimination plan, you need to go to the people. And with viral hepatitis, it means not just drug users, but people with lived experience. You need to ask them how you can do this thing. Then you need to talk with healthcare workers and go through there. But it has to be led and directed by people who use drugs, current people who use drugs, and people with lived experience. I would also say that while I have just a couple minutes left, there is no moving forward unless we change our cascade of care. If we do not find a shorter time window to test, this will not happen. We've moved mountains with every other medical event we needed to. But the one that affects drug users the most, we do nothing. Oh, we got a cure. That's okay. Well, these people aren't getting cured or they're reinfecting because a simple problem you could fix. You ask anyone who understands hepatitis C or understands any of this stuff, the option will get them tested and cured quicker. And that's what I would say. I mean, I can't pound that drum enough, Daniel.
Thanks. No, thanks so much, Nick. And I think we're going to carry a lot of these themes that you've raised, the complement what we heard from Dr. Viewer and Dr. Deshali, into the conversations for the rest of the afternoon. But I'm going to pass it back to our moderator, Ron Baldessari now.